Thank you, everyone. And during this COVID-19 outbreak, at least we're doing some innovative way of communicating with our families and our colleagues and our patients. We never thought the telemedicine would be so useful to us with the local practices. We thought only it's going to be for remotely areas, but it came in handy for us during this time. And we'll get started with the presentation. This is going to be on peripheral artery disease. I'm sure you all see patients with peripheral artery disease. Some of us see more of these patients than other specialties, but they all have generalized problems, not only related to the peripheral artery disease, but also coronary and carotid artery disease, what we call as end organ disease. They also have renal disease, these patients, and cerebrovascular disease as well. So with that, we just want to update on the risk factors for the PID. Number one is smoking. Number two, diabetes. And of course, number three is age and family history and hypertension, hyperlipidemia. And smoking accounts almost 75% of the responsible factor for PID. So number one risk factor is smoking. So if you've seen some of my patients smoking, I put my foot down before I do any procedure on these patients. I tell them to quit smoking before I do any procedures. They have to be smoke-free. And they hate me for saying that, but later on they realize that it's not that difficult to quit when somebody has to go through the procedure and quit smoking. Some of them have moved to my partner's practice from me when I say that, but most of them, they quit and they later on thank me for putting my foot down. So I really very aggressive on smokers, and this is the reason. Because this slide, if you can see, 10-year survival rate of peripheral artery patients, smokers versus non-smokers, big difference. 10-year survival rate. People who have survived 10 years, only half of smokers make it there after the diagnosis of PID. So it's just huge. So this is the reason I am really, I'm sure patients will come back and tell you also that I'm whatever, hard on them or arrogant on them or rude on them, all kind of things on me. But ultimately they do quit and they understand the reason and be happy after that. At least they live longer if they quit smoking, especially once they have PID diagnosis on these patients. And we do see occasionally the guys who don't want to quit, and we see them going down to amputations and strokes and so on. So this is another whole different ball game, talking about claudication is one presentation, and critical limb ischemia is a whole different ball game to start with. These people are very diffusely diseased. This is the end-stage PID they call chronic limb ischemia, and severe blockages at all levels. It's not just the iliac or SFA. They have popliteal disease. They have below knee small tibial vessel disease. All of them are stage-wise. I have to spend a lot more time on these patients to open these arteries to get the blood flow down to the foot. I go all the way into the pedal arch to open the pedal vessels to restore the flow to the digits to save the toes, especially if the diabetics have small vessel disease. I even go into the pedal arch to the medial and lateral plantar arteries and dorsalis pedis arteries to restore the flow to the toe. Otherwise, these people go into amputation of the toes, and that's where it starts and spreads upwards. So takes time, sometimes may take more than one procedure for them to open the same leg. So one at a time, we take care of these patients a lot longer time they take, and more sicker patients. Without restoring the blood flow, almost 40% of these patients will require limb amputation by 1 year. And 20% will die within 6 months of these chronic limb ischemic patients. Very high mortality on these patients. Once they lose the ability to walk, they go down quickly. And symptoms are mainly the rest pain, ulcers, or discoloration of the foot. Most of people come wearing shoes here with us. Even to take off the shoes on these diabetic patients will tell us a lot about their vascular disease. So what are the treatment options we have here? Number one is medical management. Only the people who come to us, the recognized or referred or nationwide, accounts only for about 10 to 12% of the patients. Other 90% of the patients are with you in your practices, in your primary care day to day. Almost 1 in 5 patients above age 50 will have PID, whether diagnosed or undiagnosed, especially if they're diabetics and if they're former smokers. Incidence is very high on these patients. So lifestyle modification, I always tell them to change their dietary habits. Number 2, to change their medications, aggressively lowering the cholesterol levels and diabetes control and blood pressure control. And of course, the walking, even they have claudication, I tell them to walk through it if they can. If it's not limiting their lifestyle, there's no need to intervene on them, invasive testing or invasive procedures on these patients, if they can improve the lifestyle with exercise and walk through them. And of course, there are some medication that will help to improve the claudication distance, like cilostazol can improve the claudication to some extent. But if they are progressive symptoms, that means they need help. Those are the patients who need help. In terms of treatments, of course, the surgery was the baseline. Originally was there, and now number of surgeries done are less and less now. More endovascular procedures are done. Of course, the angioplasty was the first one to come up with. And then we have stents. And then we have atherectomies, different types of atherectomy. We have the rotational atherectomies, rotablation, and we have CSI, and also we have the Hawk device, Turbo Hawk device, that we remove the plaque. And all these are increasing in usage, and they're all helpful also. But the restenosis rate is significantly high in these patients. That's been our challenge. In coronary arteries, CAD, I think we got pretty good control on restenosis with regulating stents. Second generation, we have third generation regulating stents. We've got pretty much control on the restenosis rate. But peripheral artery disease, it's a different, totally ball game, because it's a longer vessels, and they put through a lot of torsion and flexion on these vessels, and diffusely diseased vessels. So they do tend to progress in other areas that are not intervened, adjacent areas, and they do tend to restenose where we do these interventions. Coronary angioplasty restenosis rate is almost 50%. Stent procedure also, we're getting around 30% restenosis rate, which is unacceptable. But what are the alternatives here? How do we prevent it from restenosis? I hate to see a patient coming back 4 months, 6 months down with the same symptoms again. Worst is when they come with the gangrene or ischemic foot. So there's a small go through. This is a trend. Interventions, amputations are going down. Luckily, last 20 years, 30 years, it's been trending low. The reason is the endovascular, I think. Number of angiograms are increasing. Before, they never even did an angiogram before amputation. Now, it's more awareness is improved. Everybody at least gets an ultrasound, if not CT angiogram to get. So the bypass surgeries have gone down because these procedures from the less invasive are increasing popularity and more patient friendly, quicker recovery. They go home same day. Is become a lot more accessible to patients as well, since we're doing in outpatient facilities now. A lot easier patient to access and go home same day. So once the amputation comes in, still, even as of last year, the amputations are still high on our patients. So much of the limb saving is much better than to undergo an amputation. So if somebody recommending amputation, I always tell them, hey, get a second opinion. Not all physicians or interventionalists do the same work. Some are more aggressive and takes time to go and do the small vessel disease. Some of the interventionalists just do the bigger arteries only, iliac vessels or some of the SFAs. So I always tell them to get a second opinion to see somebody can do a better job than others as well. But most of the people who deal with peripheral artery disease can handle and do the critical limb ischemic patients. So there are different ways of doing this. The ones I do, these diabetic foot ulcers or diffuse disease ulcers, to restenose, to avoid restenosis, there's a new atherectomy device where we can see what is the plaque burden in that artery. This is called optical coherence technology, OCT, like ultrasound inside the catheter at the tip where the blade is. We do have intravascular ultrasound on a separate catheter, we do, but we don't have the combined both of them in one device. This is the first time we've had access to this kind of technology, which helps us to avoid certain areas and focus on exactly where the plaque burden is and do the atherectomy in those areas only. The reason is there's a small study my friend and colleague did in New York, Mount Sinai, the study. The restenosis rate correlates to the damage done to the adventitia. Adventitial layer is outside wall of the artery. So what he did was he was doing atherectomy with a Hawk device and sent all those samples removed from the artery to the pathologist and did analysis on these pathology specimens. When they saw the pieces of adventitial tissue in the pathology slides, those correlated percentage of patients with adventitial disruption showed almost half of these patients are there. Under those, 95% had restenosis of these patients. So it's very important not to damage the adventitial tissue. So that's the whole idea of doing this different technology, is where you can see where you're cutting. You can see the adventitial tissue coming into the blade where I'm cutting, and stop the cutting. And once I see the external, elastic lamina, so adventitial tissue where I can see the media and the adventitia, that will help to redirect the blade of cutting the plaque, removing the plaque, towards where there is more plaque burden areas in the same artery. So it's not all around circumferential plaque in these arteries. There are differences in where the plaque burden is in the different directions in the artery. So these are the examples where you can see the adventitial layers, and also you can see the plaque burden on the artery, in the arteries. And then there's a window where I can see which side my cutter is facing. So I can rotate it from outside and do the atherectomy in a different direction. So I'll show you a short video of this. This is one of the cases we did. This is a patient sent to us from our wound care clinic with an ulcer in the foot, in the dorsum of the foot. He was a 380 pounds guy. No way I could go through his groin in outpatient labs with a huge soft tissue mass to go through without having vascular complications. So what I did was in this patient is I went through the foot, pedal axis, like the radial cath we do in the radial artery. Same way we can also access the artery from below. So it's not we do everybody, but some of these patients which are high risk of having bleeding complications, and the disease is below the knee in a focal area where the ulcer is, we can access to those arteries directly. So I went retrogradely on this patient. These are the patient slides. See this medial layer, you can see clearly. It looks darker. And then you have adventitial layer. So when my blade is turned towards that layer, I'm going to avoid any atherectomy on that area. And I turn my blades onto the other side where the plaque burden is on this one. This is the plaque. This whole thing is a plaque. I can't even see the media or adventitial area. So such a long or thicker plaque burden. That's where I advance the catheter where the blade cuts through this plaque, and I stop once I see the adventitial layer so that I don't damage the media or adventitial tissue. That prevents it from restenosis. So this is a short video how it works. You can see on the side, there's also a balloon in the back of the catheter where I inflate the balloon from outside that pushes the blade towards the plaque. It's a very compliant balloon, and it can go through the plaque, and then when I stop it, I deflate it and pull back again. And repeat it until I see the medial layer and adventitial layer. And this plaque gets collected into the chamber in the front, and we remove the catheter outside and we flush and take these pieces out. So this is the total occluded vessel. I was able to open it and do atherectomy with OCT guidance visualization. We can see exactly where we are doing the angioplasty or atherectomy, and then followed by angioplasty on these patients. This is the live cuts of what I've been doing. You can see this is the case directly from my lab. And once this is all plaque, and then I see the adventitial media and I stop cutting, like when I see that. Same thing on this side, you see the adventitial layer. So I rotate away from those areas and I cut, and I see the adventitial layer coming in, and I stop the cutting there. So it's very nicely visualized and able to see what exactly where the plaque is, and then we can do selectively where the plaque burden is. So this is the results. The total occluded vessel opened up completely, and it's 2 weeks now. We did call the visiting nurse to see how the wound is. Almost healed, only quarter-size ulcer left on the foot. So this is the pre-procedure way. This is just a demonstration, and post-procedure, this is the way we take care of the plaque, remove the plaque, and angioplasty it. So these are the real plaque from my patient, removed from this patient. You see those on the sheet, aspirated from the nose cone. These are the plaque, pieces of plaque we remove from these arteries. So conclusion is that this is the well visualized catheter while we're doing the atherectomy, and exactly safely remove the plaque, restores the blood flow, better long-term results with less restenosis and less chance of perforation with this device, because we can visualize exactly where we are doing and where we can stop exactly when we see it. And also, to me, it's less radiation to me, because I have an ultrasound direct visualization of the artery. I don't have to use the X-ray as much, and I don't have to use as much contrast either. So I don't have to take pictures repeatedly to see where I'm cutting, what's going on. So less contrast and less radiation to the patient and me and the staff in the room. So it's been working out. We've been using it for the last 6 months, this technology, and it's been helping our patients. I just want to share with you guys and what we have and what's new in this field. And also I want to share with you our new outpatient facility, since we just opened the where we can do these procedures like in a hospital setting in our outpatient facility in Brownwood. Some of you have seen this, I think. If not, this is a nice cath lab we have where we have all the technology to do. Now the Medicare approved for the outpatient PCI of the coronary stent can be done in outpatient. This is the idea of doing this in a surgical center where we can do the pacemaker implants and cardiac caths and peripheral angios here safely. And these are the suites, recovery rooms, and this is the building right on 44. Thank you. Questions?
Dr. Attanti.
Yes.
I'm a podiatrist, so when I see patients and I'm going to send them, after they get their results back and they obviously need to see a vascular surgeon, I try to keep the way I answer their questions, I try to keep it really simple, because they'll say, well, what are they going to do? And I usually try to keep it really simple, and I'll say it's almost like a roto-rooter job. And I don't know if that's fair to say for them.
Yes, that's fair to say in common terms, common man language, yes.
Okay. I didn't know if there's anything else that you might recommend to educate them, but in a simple way so they understand it and they also don't get like terrified,
Right, that's okay. That's fine.
Thank you.
Yeah, and thank you for offering. And if you have any questions, they have anything, they can go on our website also.
Okay.
A lot of videos online that explains to them. And then all these talks I've given before, they recorded it, and we have them on our website as well on education.
Thank you.
Any other questions? So there's a question there, is restenosis rate, is it lower than other devices? Yes, definitely. It is lower. Almost half of it. What I'm saying is less than 50% of other devices that I've used in the past. And also the balloons, we also have drug-coated balloons now we use that also reduce the restenosis rates following the atherectomy. And if you have to put a stent, there are drug-eluting stent in the peripheral. And also I used something called as Supera stent, which is a coil interwoven stent, which does not fracture. Main reason the restenosis happening in the other nitinol stents is that they have stent fractures because of the torsion and bending of the stents in the vessels. So the interwoven stent, the Supera stent, the fracture rate is almost none, 0. So the restenosis on these stents I use also much less. So a combination of atherectomy and drug-coated balloon on the Supera stent, restenosis rate is, in my practice, is around less than 10% in single digits. Who else are certified to do this procedure? Dr. Salak does them in our practice. Dr. Rivero and all other interventionalists can do this. And there's a very small or little learning curve for them to catch on. And there are more and more physicians are using them in the state now. So a few of us here in Central Florida and Gainesville and some in Jacksonville. Okay, this other question is, what is the smallest vessel you can access? There's no smallest vessel. We go through the digital vessels also. And the radial artery is about 3 to 4 millimeter size. And most of these pedal vessels are 4 millimeter size. So accessing the digital vessels also I've seen, but I have not done it myself. And next question is, how long are these patients followed up to see if there is restenosis? We do the follow-up ultrasound 3 months, 6 months, and 1 year. If they're open after 1 year, we do just annually or go by the symptoms. That's a recommendation. They're going to have restenosis. The restenosis happens within the first 3 to 6 months. That's a time frame we vigilantly watch for this. Yes, the other question is, how does the calcification of the vessel affect the procedure? Yes, if they're calcified vessels, it's hard for any device, even any best device. We don't have any device that can tackle the calcium, but at least it will break up the plaque around the calcium that makes it more compliant for balloon expansion and be able to put a stent without having unexpanded stent. We'll be able to push the plaque to the side to stretch the vessel wall. So calcium is a challenge if they're diffusely calcified vessels. That's what I've seen with my experience with this. Thank you again for participating, and we will repeat this hopefully on an evening session sometime. Some of them who cannot attend, busy with the work, maybe we can do it after work, maybe like 5:30, 6 p.m.